You're listening to Medscape's In Discussion series on idiopathic pulmonary fibrosis, a podcast where thought leaders and clinical experts share their diverse insights and practical ideas for optimizing patient care. This series is hosted by Dr. Jeff Swigris, Professor of Medicine in the Interstitial Lung Disease Program at National Jewish Health in Denver, Colorado. Dr. Swigris directs research centered on how patients live with and experience interstitial lung diseases, how to best assess that experience, and how quality of life may be improved for patients suffering from interstitial lung disease. Relevant disclosures can be found with the episode show notes on medscape.com or the Medscape app. The topics and discussions are planned, produced, and reviewed independently of advertisers. This podcast is intended only for U.S. healthcare professionals.
Welcome to Medscape in Discussion. I'm Dr. Jeff Swigris, and today we'll be discussing interstitial lung disease, or ILD, and specifically a form of ILD associated with connective tissue disease, or CTD. We give this entity the name CTD-ILD. ILD is an umbrella term that we use, and when we think of the causes or the etiologies of ILD, I like to group it into four big buckets. The first is exposures, a category that I call mold, mildew, birds, and bacteria, things that patients might inhale, aerosolized, typically organic antigens. Other things that fit into the exposure category are things that can be inhaled, like dusts, medications, and things like external beam radiation therapy, etc. So broad category exposures. A small percentage will have what we call familial disease, so a first-degree relative with interstitial lung disease. The third category is idiopathic or unknown cause, and the most common entity in that category is IPF, or idiopathic pulmonary fibrosis. And finally, the fourth category is ILD associated with systemic autoimmune disease, including connective tissue diseases, which is going to be the topic of our discussion today. To help me disentangle some of the complexities associated with CTD-ILD, I am just delighted to have my friend and colleague, Dr. Sonye Danoff, an internationally recognized leader in the field of ILD. She is professor of medicine in the Division of Pulmonary and Critical Care Medicine and director of the Interstitial Lung Disease Program, as well as associate director of the Myositis Center, all at Johns Hopkins University School of Medicine in Baltimore. I really can't think of a better person to have here today to talk about this topic. Sonye, welcome.
Thank you so much, Jeff. I'm so excited to have an opportunity to talk with you about this.
Great. Before we dig into the discussion, we like to hear how our guests have actually landed in this field. How did you get an interest in interstitial lung disease, and specifically your interest in connective tissue disease-related ILD?
Like a lot of people in pulmonary, my choices were directed by the patients that I interacted with. And I had a very young woman, a 30-year-old nurse who I took care of as an early fellow who presented having come from being the head nurse of a trauma center. She very abruptly developed shortness of breath, came in with a pneumothorax. Unfortunately, at that time, which was over 20 years ago, we watched her as she progressively became more short of breath, ultimately went to the ICU, and then very sadly died. I was struck by the fact that this young woman who was presenting with what we would now consider a rapidly progressive interstitial lung disease in the context of a previously unrecognized connective tissue disorder, she really spoke to the fact that this was an area of need, and that shaped my career afterwards. I have always been very interested in understanding the interstitial lung disease that happens to groups which maybe haven't had as much attention, so minority populations, women, and that's what really brought me into connective tissue disease, ILD.
In that case, highlights one of the important epidemiological features of CTD-ILD. We think of IPF, idiopathic pulmonary fibrosis. Most commonly, we're dealing with patients in their mid and late 60s at the time of diagnosis. And given the propensity for systemic autoimmunity to affect women and certainly patients on the younger end of the age spectrum, a lot of our patients, like the one you described, are young, vibrant people looking forward to several decades more of life, and then this devastating condition hits them. Okay, well, let's dive right in. Let's start with rheumatoid arthritis. Rheumatoid arthritis, or RA, I'm sure we're going to use that acronym here throughout the conversation. RA is certainly one of the most, if not the most, connective tissue disease-related ILDs. The most common pattern that we see on CT scan, or if we were to get a surgical lung biopsy in a patient with RA and ILD associated with it, would be usual interstitial pneumonia, or UIP. We know that's not the only pattern, it's just the most common one. So if you have a patient who presents with RA-ILD, the pattern is UIP, talk to us about how you approach drug therapy for that patient.
RA is a really complicated topic, and it's particularly complicated because we see patients who are diagnosed with RA based on a rheumatoid factor and evidence of arthritis. One of the perspectives that I have now, having worked in myositis for a long time, is that we also can see rheumatoid factor being elevated in patients with autoimmune myositis. So the first thing I like to do is make sure that we have the right disease entity. Sure. The patient really has RA, that they have an erosive arthritis. I think the second thing that makes RA complicated is that many of the therapies that are used for treatment of joint disease can actually have impact on lung. As you pointed out, one of your big buckets was this external drug associated. So really looking thoughtfully, making sure that a patient's not on a medication that can be associated. And although methotrexate tends to have the bad reputation, it's probably the one I'm least concerned about. I'm more concerned about TNF inhibitors, which, although very rarely, can be associated with interstitial lung disease. And then we really get to the issue of patient having a systemic disorder as well as interstitial lung disease. And so is there a single drug that can be used to treat both the systemic disorder as well as the ILD? And this is a topic where you really have to have a very thoughtful conversation with the patient, because this is where joint decision-making really comes in. I might start by treating with azathioprine, which is an immunosuppressant that is both very effective for interstitial lung disease as well as effective in joint control. If the patient does not improve with that, then I might think about rituximab and really focus on the inflammatory component. Perhaps the biggest change in the field has been based on a couple of recent studies, including the INBUILD study, which showed that patients who have progressive fibrotic disease that gets worse even though you've done all the right things. So if my patient gets better, stabilizes on an immunosuppressive, I'm going to stick with the immunosuppressive. We're going to think about, is there a lull in disease activity? Can the patient be tapered? If the patient continues to progress, then I'm going to think about using an antifibrotic agent based on the INBUILD study.
Very helpful. And there's a lot to unpack in there. I wish we had an hour just on that topic alone. Of course, we're talking to our rheumatology colleagues and trying to come up with the right regimen that's going to control joints. And also we're going to target the lungs as well. Even if it's UIP, if you can confirm RA, are you more likely to start with an immune suppressant, knowing that there's probably lymphoid follicles, there's an inflammatory component to the UIP or a top UIP?
Yes, I do tend to start with an immunosuppressive therapy. And I know that this is an area where there's still a lot of debate, and there perhaps isn't the data to decide what the right answer is, but that would be my approach to it. Having more tools in the armamentarium makes life more complicated, but in a good way. So the fact that if you find that the patient progresses despite an immunosuppressive, that you can then consider adding an antifibrotic just really adds to the options available for the patient.
Yeah. Okay, let's shift gears for a minute. So I want to mention this entity IPAF, or interstitial pneumonia with autoimmune features, but I do want to get on my soapbox for just a minute and remind the audience that IPAF, these are folks who we say have the flavor of having a systemic autoimmune disease that is driving their ILD. It is not meant to be a diagnosis. It is meant to be a research classification. And so you get patients who are referred to you that, oh, the diagnosis is IPAF. What do we do? Let's remind ourselves, again, IPAF is a research classification and it is not a clinical summary diagnosis. So I can, in fact, have a patient, for example, who I say has idiopathic pulmonary fibrosis even as their clinical summary diagnosis, but who meets IPAF criteria. So can you help us out? What's the approach that you take? If somebody comes in and meets IPAF criteria, how does that influence your approach to their drug therapy?
I will join you on your soapbox. While IPAF had a purpose in terms of trying to identify a group of patients who need to be understood better, and unfortunately what's happened is that it's morphed into this clinical designation, which is really unhelpful as far as I'm concerned. What it really points out is that for many patients who present with ILD as an early or principal component of their systemic autoimmune disease, they may not meet criteria that have been defined by rheumatologic associations. It doesn't mean they don't have the disease. It just means they have a different flavor of the disease. So just as an example, I'm sure you're very well aware that the antisynthetase antibodies are included in the list of potential defining features for IPAF. And my view is that if you have a patient who presents with PL12 and interstitial lung disease, they have an autoimmune disease, they have antisynthetase syndrome. What I think is very helpful is, number one, to not use the IPAF designation. Look at what features make you think that a patient has an autoimmune component. If it's an autoantibody, then I tend to follow the autoantibody. So for instance, if it's a defining autoantibody like PMSCL or MDA5, and the patient has just interstitial lung disease, I will treat along the pathway for that disease. If I have a patient who has very strong features of, say, scleroderma, they have severe Raynaud's, they have esophageal dysmotility, they have pulmonary hypertension, I'll treat down a scleroderma pathway. Mm-hmm. But the key is really to throw out the concept that in order to have a diagnosis of a systemic autoimmune disease, that you have to meet all of the kind of classification that has been defined very appropriately, but from a different lens, from the lens of patients who present with more of their systemic disease rather than their lung disease.
Right.
I think you have to tailor your therapy, but I would generally follow a pathway of immunosuppression in patients like that.
Mm-hmm. So immune suppression first, and then if they progress, if there's not another immune suppressant that you might add, either in combination or as an alternative, you're thinking about adding nintedanib, for example, potentially.
Yeah, my general expectation is that a patient who has an inflammatory lung disease will actually get better. It's not that they will get worse less quickly. They will actually get better when I treat them. Mm-hmm. So what I'm really looking for in treating these patients is improvement in lung function, or at least stabilization of lung function. And that often will take multiple types of immunosuppression. I wish it were easy to say, okay, well, you go on this drug and you take this dose and that's how it's going to fix you. But especially with patients with connective tissue diseases, you really have to be very willing to think about whether you need to add another immunosuppressant or change immunosuppressants or rethink it. Is the reason the patient's not getting better not because their ILD is getting worse, but because they have pulmonary hypertension now. Mm-hmm. And so it really does require that kind of constant reevaluation to try to assess that. And then certainly there are patients who, despite all appropriate immunosuppression, will have progression of fibrosis. My goal is that they're going to get better and that they will never see an antifibrotic.
So let's talk about systemic sclerosis or scleroderma-related ILD or SSC-ILD. We know that ILD is really common in patients with systemic sclerosis. And you mentioned treatment options. And now the field of systemic sclerosis, treatment options are growing, and it might be creating more confusion for us about where these different therapeutic options fit in the treatment paradigm. So recently, tocilizumab came on the stage and was approved by the FDA because of its effect on preserving decline in FVC. Mycophenolate, at least in large trials, has been shown also to be effective. We have cyclophosphamide. Talk to us about where tocilizumab fits into this treatment paradigm. And if you want, why don't you talk a little bit about how we think about it and why? Why does it seem to be for this specific subgroup?
This is a really good example. I often tell the people that I work with that you never do a randomized controlled trial of wearing a parachute when you jump out of an airplane, because sometimes what you need to do is use all of the data that exists and you don't have to actually test everything. And so I think that one of the reasons tocilizumab has had a lot of focus on it is because it's a randomized controlled trial. And interestingly, it was done in a very early patient population. Mm-hmm. The primary endpoint was actually not lung disease, it was skin disease, and it failed to achieve its primary endpoint, which was to reduce the evidence of sclerosis in the skin. The other important thing is it didn't actually alter quality of life endpoints. So it was typically in a group of patients who were otherwise untreated. What it tells you is that when you're dealing with a systemic inflammatory disease, being on an immunosuppressant is better than not. And so my approach is you look at the patient as a whole, that this is another option for patients, but I'm not sure that I would be more likely to reach for tocilizumab than mycophenolate in a patient who was previously untreated. I think that it is going to probably take another 10 or 15 years before we can really recognize which are the patients who are most likely to respond to tocilizumab. My presupposition when I treat a patient is that their lung function is going to get better.
Yeah.
And so again, what I'm looking for is actually improvement in lung function as opposed to slowing the rate of decline. So I think that the jury is still out on exactly where tocilizumab is going to be used. But for me, it's still probably a second line agent rather than my first line agent.
Right.
And I would still reach for mycophenolate first.
Yeah. You brought up the really good point that the trial in which it was studied, the primary endpoint was skin, FVC was a secondary endpoint. And these were patients who were recently diagnosed, patients who had robust inflammatory markers. So we're talking about early active disease. And I think if skin is a major manifestation, I'm certainly not reaching for tocilizumab. We know that both mycophenolate and cyclophosphamide have some beneficial effects on skin. Still a lot to learn about that entity, about combination drug therapy and systemic sclerosis for sure. Okay, final question. This really gets into your wheelhouse on antisynthetase and the myositis spectrum. You touched a little bit on your approach, but let's get a little bit more specific. You have a patient with antisynthetase. So somebody with fairly characteristic antisynthetase syndrome has ILD. Let's say they have an anti-Jo1 or PL7 antibody. How do we think about therapy for them as a starter?
Sure. So the way I usually divide this is based on the acuity at presentation. And often we can see the patients who have come in because they have muscle disease and then they're found to have some lung disease. Maybe they're already on some immunosuppression. Maybe they're not. But for a mild patient who has interstitial lung disease, I'll certainly be watching them using pulmonary function testing. But if their symptoms are really very mild or they don't really have symptoms, they just have a radiographic finding, I may just watch them. Or I might start them on a steroid-sparing agent without using a steroid.
Are you likely to reach for one over another for your steroid-sparing drug?
The biggest issues are, one, do they have joint involvement, in which case I'd prefer azathioprine. And two, are they planning to become pregnant? Because you can't use mycophenolate in a patient who had any intention or potential for pregnancy. So those would push me towards azathioprine.
How about cyclosporin? Do you guys use calcidiurate antagonists at first line?
We do, but we mainly use tacrolimus and mostly use it in patients who have MDA5.
Got it.
So that's really where I found the sweet spot, is that tacrolimus is incredibly effective in MDA5, even at very low dose.
In combination with mycophenolate or monotherapy?
Monotherapy. We actually use IVIG in our MDA5. MDA5 is often associated with the rapidly progressive ILDs, what we used to call the acute interstitial pneumonias. For those patients, we'll often use IVIG and steroids up front. And then if they have very severe disease, we'll certainly add a steroid-sparing agent. The choice of the steroid-sparing agent is going to depend on the severity of disease. So if the person's on azathioprine or mycophenolate, we might continue that. If they're not, we might start with tacrolimus as their first drug. Then we taper therapy as tolerated based on how patients are doing.
Is there a role for nintedanib in this population?
There probably will be some patients who have progressive fibrosis despite appropriate therapy, but my general experience is that particularly myositis, where it's a very highly inflammatory disease, that we can often stabilize and or improve lung function. There probably is a subset of patients who will have progression, and that would be the patient population you would be considering for an antifibrotic. And of course, the new MINT trial is going to actually look at that directly. That'll give us a little bit better understanding about which patients may benefit from an antifibrotic and how that is integrated with their immunosuppressive therapy.
Fantastic. Well, before we close, let me just summarize a few key points that Dr. Danoff brought up. One is certainly talking with your patient and using shared decision-making. And also, probably nowhere else in the ILD world is it more important to take a multidisciplinary approach. We really need to lean on our rheumatologists and work with our rheumatologists to find the best therapeutic regimen for our patients. You heard Dr. Danoff remind us about IPATH being a research classification. You heard her remind us to tailor our therapy based a lot on pace of presentation. So those patients who are presenting with more severe and or rapid decline, inflammatory, we're going to be much more aggressive. The other highlight that I'll take away is that we have a lot to learn about all of these entities, about what drugs work best for which patients, for which phenotype within each connective tissue disease. Sonye, there are things that you'd like our audience members to either think about differently or do differently, or just a couple general reminders when they are taking care of their patients with CTD-ILD?
Sure. And you know this well because you've already been the recipient of this. It's never the wrong idea to ask a friend. And so when you encounter a patient where you're really struggling or where you're uncertain, referring to an ILD specialty center, I certainly reach out to my colleagues at many different centers to ask for their input and have really gained incredible wisdom from many of my colleagues elsewhere. The second thing is to be very conscious of what the side effects of medications are. Certainly immunosuppressives have to be monitored very carefully, first do no harm. And then shared decision-making with the patient. None of these therapies are going to be easy, and we need to inform our patients about what the risks and benefits are and work with them to find the therapies that are best suited to them.
That's great. Well, Sonye, thank you so much for joining me today. We really appreciate your expertise and your insight. Thanks so much.
Thank you for inviting me. It was great getting a chance to chat about this.
And to the audience, thank you for listening to this conversation on connective tissue disease-related ILD within the Idiopathic Pulmonary Fibrosis podcast. Our guest has been Dr. Sonye Danoff. There's much more ahead in the coming episodes, so please be sure to check out Medscape mobile app and share, save, and subscribe if you enjoyed this episode. I'm Dr. Jeff Swigris for Medscape in Discussion.
Thanks for listening to Medscape's In Discussion Idiopathic Pulmonary Fibrosis podcast series with our host, Dr. Jeff Swigris. Be sure to look for more In Discussion episodes wherever you get your podcasts. Check out medscape.com or the Medscape app for show notes, links, and more information on idiopathic pulmonary fibrosis.